prostate cancer treatment-related side effects and management. Erectile dysfunction. Erectile dysfunction is defined as the persistent difficulty getting and/or maintaining an erection sufficient for satisfactory sexual activity, and it is a common side effect of prostate cancer treatment. Surgeons will often try to perform a nerve-sparing procedure. However, nerve damage can occur following a radical prostatectomy. These nerves can take 2 or more years to recover, and while the rates of erectile dysfunction vary, over half of men will require the use of treatment aids to get or maintain an erection sufficient for penetrative intercourse long-term. If men are under 60, have good erectile function and a bilateral nerve-sparing procedure, they are more likely to recover their natural erectile function than those aged over 60 with pre-existing erectile dysfunction. Treatment aids will most likely be necessary for those men that have a non-nerve-sparing radical prostatectomy, as they will no longer have the nerves necessary to obtain a natural erection. Radiotherapy can also result in erectile dysfunction. There may also be a delay in development of erectile dysfunction following radiotherapy treatment. When treating localized prostate cancer, radiotherapy may be combined with a course of androgen deprivation therapy, ADT. Most men on androgen deprivation therapy can expect to have erectile dysfunction and a loss of libido or sex drive, as this treatment depletes the body of testosterone. Urinary incontinence bother. The most common type of urinary incontinence men experience post-prostatectomy is stress urinary incontinence. It involves the involuntary leakage of urine when pressure is increased on the abdomen, pushing down on the bladder. Often this occurs with coughing, sneezing, or heavy lifting. How long and how much a man will leak urine for varies, but most are pad-free or require a light pad at 1 year post-surgery. While the majority of men recover their continence with time, it is important to note the risk that around 5% of men will be completely wet at 1 year and may require treatment for this. While radiotherapy is less implicated in urinary incontinence, men can develop irritative lower urinary tract symptoms such as frequency, nocturia, and urgency, which may be bothersome, though these can also improve with time. Penile shortening. A reduction in penile length occurs following radical prostatectomy treatment and may range from 1 to 3 centimeters. Anorgasmia, orgasm dysfunction. Changes to orgasm sensation and ability to ejaculate can occur with surgery and radiotherapy. Some men report some discomfort and others a heightened sensation of orgasm. During surgery, the prostate gland and seminal vesicles are removed and vas deferens clipped, causing disruption to the ejaculatory pathway. This means all men post-radical prostatectomy will be unable to ejaculate during orgasm. Some men may also experience climacturia, which is an involuntary leakage of urine during orgasm or when aroused. Bowel dysfunction. Radiotherapy can have a negative impact on bowel function, especially within 6 months of treatment, with men reporting bowel bother, frequent or loose stools, and bloody stools. The severity of symptoms can range from mild to severe, requiring intervention. Treatment for side effects. All patients undergoing radical prostatectomy should see a continence physiotherapist prior to their procedure to learn pelvic floor exercises. Evidence shows learning how to correctly contract the pelvic floor prior to surgery helps to recover continence quicker than if they received no pre-surgery pelvic floor training. Patients should also see the continence physiotherapist a month after surgery to assess their postoperative continence recovery. If patients are significantly wet at 1 year following treatment, it is advised they see a urologist for consideration of further surgery to treat post-prostatectomy incontinence. This can be either with a sling device or artificial urinary sphincter. Continence physiotherapists can also assist with managing overactive bladder symptoms, educating patients how to retrain the bladder to store and empty urine. Treatment options available for erectile dysfunction are PDE5 inhibitors, a vacuum erection device, and intracavernosal injections. These are first and second-line treatments for erectile dysfunction. If these fail, patients may be suitable for a penile prosthesis, which is the third-line treatment available. Only if the patient has exhausted the first and second-line treatments may they be considered for a penile prosthesis, as it is an irreversible surgical procedure. Penile rehabilitation is commonly recommended for treatment of erectile dysfunction post-radical prostatectomy. Patients are instructed to take PDE5 inhibitors regularly to try to provoke erections post-treatment, thereby encouraging blood flow into the cavernosal tissue to maintain penile health and prevent scarring. The literature varies on how effective penile rehabilitation is on recovery of erectile function, with most of the literature coming from animal studies. However, some studies do show a clear benefit, with recovery of erectile function more likely in men on penile rehabilitation compared to those not. The regime can involve the use of PDE5 inhibitors combined with a vacuum erection device and/or intracavernosal injections. PDE5 inhibitors can be taken either on demand once to 3 times a week with stimulation, or a low daily dose taken nightly followed by a full dose and stimulation at least once a week. A vacuum erection device can be used daily from catheter removal and in combination with a PDE5 inhibitor to try to achieve an erection sufficient for intercourse. PDE5 inhibitors will not work without stimulation or nerve function. It is recommended patients try a full dose of PDE5 inhibitor on at least 6 different occasions with stimulation before it is considered treatment failure. Intracavernosal injections are a second-line treatment for erectile dysfunction. Vasoactive substances are injected directly into the corpus cavernosum to achieve a functional erection. They are around 80 to 90% effective at achieving an erection sufficient for intercourse, but require education on how to prepare and administer the injection before use. Risks associated with using intracavernosal injections are scarring, penile pain post-injection, and priapism, which is a prolonged erection for over 2 hours and is a medical emergency. Both vacuum erection devices and intracavernosal injections can be effective at achieving an erection irrespective of nerve function, so can be useful tools in treating erectile dysfunction in men with non-nerve sparing surgery, with pre-existing erectile dysfunction, and those that have treatment failure with PDE5 inhibitors. Men may feel a loss of masculinity following prostate cancer treatment and have a fear of failure being able to perform sexually. This can result in avoidance of situations involving intimacy for single and partnered men. It is important to encourage communication to couples and suggest counselling with a psychologist or sex therapist may be of benefit to improve intimacy. Some possible symptoms following prostate cancer treatment indicating need for review by a specialist. Within the first 1 to 2 weeks of commencing radiotherapy treatment for prostate cancer, if your patient is suffering from severe acute diarrhea and/or cystitis, it could be an indication of radiation sensitivity syndrome. Radiation proctitis is radiation-induced inflammation of the rectal mucosa, which can occur following radiotherapy for prostate cancer treatment. Acute proctitis can occur in 13% of patients in the first 3 months of radiotherapy. Chronic radiation proctitis occurs in 5 to 10% of patients and often follows on from acute proctitis. Symptoms can include rectal bleeding, changes in bowel habits or rectal discomfort, diarrhea, and increased bowel motions. Patients need to be reviewed by the radiation oncologist as they may require a colonoscopy to rule out rectal cancer, determine the cause of bleeding, and provide treatment if necessary. Radiation cystitis is a rare long-term complication of radiotherapy and can occur years following radiation treatment. Symptoms may include hematuria, suprapubic pain, frequency, urgency, and dysuria. If radiation cystitis is suspected, patients should be referred to a urologist, as they may require a cystoscopy to exclude a bladder tumour. If the bleeding is ongoing, they may require hyperbaric oxygen treatment. Interpreting prostate-specific antigen (PSA) blood test results following radiotherapy can be challenging. It is important to note that PSA should not rise post-treatment and can be an indication of biochemical recurrence of prostate cancer. It can take 12 to 18 months for the PSA level to decrease following radiotherapy. If a patient has a PSA rise, repeat the test in 6 weeks. If the PSA remains elevated, refer to the radiation oncologist or treating specialist. Following radical prostatectomy, the PSA level should decrease to an undetectable level at about 6 weeks post-surgery. An undetectable PSA reading is less than 0.1 microgram per litre. Patients experiencing ongoing or sudden onset of lower urinary tract symptoms following prostate cancer treatment in the absence of a urinary tract infection should be referred to a urologist for review. If they have a poor flow or have difficulty passing urine, it may be an indication of a stricture, while frequency, urgency, and nocturia may indicate detrusor overactivity. If a patient has recurrent urinary tract infections, it could be due to a foreign body left in the urinary tract. Patients that experience ongoing urinary incontinence, where they have little to no control of leakage at 1 year following prostatectomy, should be referred to a urologist for review. You can also refer the patient to a continence physiotherapist who can provide a comprehensive continence assessment and education on pelvic floor exercises. Men experiencing erectile dysfunction that fail first-line treatment, PDE5 inhibitors, may be referred to a urology department to discuss further treatment options available. Many urology nurses are trained to teach patients how to use vacuum erection devices and intracavernosal injections. Prostate cancer metastasizes most commonly to the lymph nodes and bone. If a patient presents with bone pain and a detectable PSA following prostate cancer treatment, it may be a sign of disease progression.